Good evening, everybody, and a warm welcome to you all here to this evening's inaugural lecture by Professor Jonathan Hill. It's a real pleasure to see so many of you gathered here to listen to what I'm sure will be a really interesting session this evening. For those of you who don't know me, I'm Professor Pauline Walsh, and I'm the Pro-Vice-Chancellor and Executive Dean for the Faculty of Medicine and Health Sciences. And this is one of the real enjoyable parts of my job, actually, is to host these inaugural lecture series and to really get to hear about the different things that staff within my faculty are doing, because on a day-to-day level, we don't actually know the detail as much. So I'm sure for some of you here today, who, although you work in the faculty, you may not know Jonathan's specific work. So I'm going to start by just saying a little bit about Jonathan as by way of introduction. And Jonathan is a professor of physiotherapy, and he's the director of research for the School of Allied Health Professions at Keele, and also works in his research area within the School of Medicine. He's internationally known for his research in back pain and wider musculoskeletal pain research through clinical trials and other applied clinical research studies, focusing on improving the quality of care given to people with musculoskeletal disorders. And I'm stood up here today with foot pain and knee pain and thinking there's a whole bunch of people in here who probably I ought to be talking to, but, you know, maybe. He initially came to Keele in 1999 to work as a research assistant on the Panther trial led by Prof. Jezik, and we've just not managed to get rid of him. So, I mean, again, for those of you that don't know, I'm just here thinking, Panther trial? Okay, maybe we might get some explanation about what that actually is. So a few years later, he stayed at Keele as the trial coordinator for Professor Elaine Hay and Professor Nadine Foster's APEX acupuncture trial. In 2004, he started a Keele Acorn PhD fellowship to develop and validate the well-known StartBack tool, and in 2008 was successful in obtaining a postdoc fellowship from the Arthritis Research Council. The fellowship supported his role in the StartBack trial, and that led to him being first author on the highly cited StartBack paper in The Lancet in 2011. Very good. That paper demonstrated the clinical benefits and cost-effectiveness of a risk stratification approach to managing low back pain in primary care, and it's hard to overstate its international impact. From 2011, he continued his work with Prof. Elaine Hay and Prof. Nadine Foster on risk stratification, getting involved in 2 large programmes they each got funded. But around that time, he also saw a change in his research development as he started applying and being successful in getting his own research projects funded. These included developing and validating the widely used musculoskeletal health questionnaire in collaboration with Oxford University, leading to the MSK Tracker Digital Health Project and an EU Horizon project called Backup that explored personalised prediction models for people with back pain. Jonathan became the AHP School Director for Research in November 2020 and Professor of Physiotherapy a few months later in January 2021. His inaugural lecture was delayed by over 18 months due to COVID, and so it gives me great pleasure to welcome him now to give his inaugural lecture, How Can We Improve Primary Care Management of MSK Pain?
Well, thank you, Pauline, for that great introduction. It's a real pleasure to be able to give this inaugural lecture. I've been feeling a bit nervous about it. But, you know, thank you, everyone, for turning up. This is, it's really amazing to see so many people are here. So thank you for making the effort. It means something to me. So let's jump in. I've got this slightly complicated title. It's quite a challenge thinking about how we answer it. I wonder what you think the answer is. I thought it was appropriate to start with a quote. I've got two machines I've got to move on. So, the quote here is, "The good physician treats the disease. The great physician treats the patient who has the disease." Here is a patient who sent me a photo. She's an 81-year-old with degenerative spinal stenosis that's been confirmed from an MRI scan. It showed degenerative spinal changes causing moderate lumbar canal stenosis at L5-S1 level, no significant disc bulge or protrusion. She scores 8 out of 10 on a scale and looks great on our statistics, but it's also my mum. And she's here. I think we need to just remember at the outset that everything we're doing as research is about people, and those people, unfortunately, are often suffering, aren't they? So we've got a responsibility to collectively do something about reducing that suffering. And I guess that's what I want to kind of think through, talk about, get your feedback on as well when we have the Q&A, and let's make some progress in this, unfortunately, at the moment, not a terribly good area to have a condition, because we're not doing a terribly good job at treating it. So this is the overview. I've put it into hopefully 3 15-minute bite-sized bits. One is a sort of outlining the problem. Then I'm going to be talking a little about me, my academic journey, some nice photos to see. And then, I guess, my vision, my research going forward, and trying to distill, I guess, some of my ideas around that, and it'd be great to have some feedback. So that's the plan. So let's jump in. Probably the best place to get a sense of the current state of musculoskeletal health, certainly in the UK, is to go to Arthritis Research UK's, Versus Arthritis, let's get the right name right, Versus Arthritis, to their reports. One in 2021, one in 2023, for musculoskeletal conditions. Now, when we say musculoskeletal, we often use MSK as shorthand, and apologies if I do that throughout the talk. It tends to be just easier to say MSK. What do we mean? I mean, this is something that affects people's lives across the whole of their life course. And it's a lot of different conditions all wrapped up into one name of MSK. It's things like osteoarthritis and back pain, knee, shoulder pain, hip pain, as well as things like osteoporosis and the sort of slightly rarer inflammatory conditions, such as rheumatoid arthritis. All of that comes under that umbrella of MSK. So the report highlights that there's over 20 million people in the UK who have are living with musculoskeletal pain. Now, that's a third of the population. And 5.5 million people who are described as having high impact MSK pain. So that's pain that's severe enough to be affecting their activities of daily living. Again, 5.5 million, how many is that? That's roughly 10 to 12% of the population, which is a big amount of people. Each year, 1 in 5 adults will visit their GP for an MSK problem. And one of the things you might have seen it coming up in the news recently around MSK problems is that not only is it costing a huge amount to the NHS, 6.3 billion, I think, the latest suggestion is, and it's about third in the sort of spend of NHS spending, and it's consistently been that for a while. But actually, the thing that's causing it to come into the news is because we're seeing that it's causing a lot of sickness absence and inactivity economically. There was something in the news only a couple of days ago, I don't know if you saw it, 7.8 days on average now per person being as time off work each year, and that's gone right up in the last couple of years. And the two leading causes of that time off work is stress and musculoskeletal. And musculoskeletal just on its own led in 2021 to, the figures are 23.3 million days off work, which is why the government at the moment is getting so interested in it. So that gives us a sense of what's going on. In terms of the sort of public health piece around this, I thought it would be helpful just to outline some of the social drivers and lifestyle drivers. So you can see particularly the things in blue. The prevalence is higher with age. It's particularly higher with those in the most deprived areas, particularly women in the most deprived areas, and obesity and not achieving 30 minutes of physical activity are the sort of lifestyle factors that really come through. This was a report that was done last year by what used to be called Public Health England and is now OHID, or the Office for Health Improvement and Disparities. And what that means is that the sort of musculoskeletal impact clusters in certain communities. It's not equally spread across our population. Here's a map that George, Ross, Marty Parker have been working on, based on doing large surveys in the Staffordshire area. And what you've got there is all the little neighbourhoods as well. And you can see you've got some areas with light green, 5 to 10% of the population have got chronic high-impact pain. And yet some areas, particularly around Stoke-on-Trent, it's up as high as 30 to 35%. And I put a quote here from Elaine Hay, which says, "We need a paradigm shift in the way that health, social care and public health researchers work with each other." Why? Because once you see a map like this, you realise it's not just a health issue. This is a public health, a social and a health issue, and therefore we need to sort of tackle it through that context. So how are we doing in the health service? Well, I said I was going to focus on primary and community care in this talk and how we improve it. If you go to the big sort of national GP patient survey, so lots and lots of people fill this out for their GP practice every year, and you can focus in on this particular tool that's available and look at just the people with musculoskeletal problems. So I've taken the ones with arthritis and back pain. And what you find is that over the last few years, starting in 2018 through to 2022, patient experience has not been improving. If anything, it is actually deteriorating in some things, like overall experience. It's really dropping quite a lot, by 10% in 1 year. And when you look at things like, do patients feel that they had a care plan agreed, or did they manage to discuss what was important to them in the consultation, that's actually the worst figures of all the different major conditions. Okay, so there's something we're not getting right in terms of patient experiences when they go and visit the GP. It's quite hard to work out what's happening in the physio kind of community MSK service world. But here's some data I've put together. Some of you will hear in my talk about the musculoskeletal health questionnaire. Pauline mentioned I'd been involved in leading the work around developing that. It gives a score from 14 questions that patients complete of 0 to 56. The lower the score, the more severe somebody is in their symptoms. And I've shown here what some of the means are from patients who do, where we've had cohorts or samples from different settings, pre-pandemic and post-pandemic. The reason I've had to go to some of my own data for this is really there just isn't any national data available that we can find. And I'm just going to focus in initially on the GP setting. Pre-pandemic, patients were scoring 29.1. You can see on here. Let me just sort of circle it with the mouse so you can see it's just there. Now, FCPs, that's the term we give first contact practitioners. They're the physios that are coming in to support general practice to reduce the burden in terms of their workload. And initially, pre-pandemic, these FCPs were being given the sort of easy-to-treat patients, and there was quite a lot of nervousness about FCPs. And you can see that their patients were a little bit milder. They were at 34. And then as you sort of come down the pathway in occupational health, 30, physiotherapy clinic, 27, that's from Roanna's service in Sandwell and West Birmingham, that data. And then an interface service, and this is from the Hayward, we're down at 24. But look at the same groups post-pandemic. We're now seeing the FCPs are seeing people at an average of 23, which is really a lot more severe. That's worse than at the interface service. In the past, to get to an interface service, you have to fail your physio community service, and then you get through. So, it's quite a different group of patients. As for general practice, that's gone down to 25 from 29. Now, the way that we recruited people for the START MSK trial and for the MIDAS GP study are very, very similar. So I think I'm not too worried as how we've recruited them that's causing the difference. There's about a 5-point reduction in occupational health settings taken from a physio clinic in Glasgow. Again, Roanna's service is seeing sort of 4 to 5 point reduction. Now, if I go to the military, their patients, and I only know pre-pandemic, their patients go in at about 30. They get a huge improvement over time in the military because they get the opportunity to really kind of do the rehab piece. They get a change score of about 19 points on average. Okay, pre-pandemic, the physios were seeing a score change around 10 to 12 points. In our START MSK trial, we saw a change in the grey here of up to 38.6, so just over 9 points. Now that's changed to just a 5-point change in the latest survey that we've done. So a halving of how well people are getting treated. So we are unfortunately moving backwards. And just out of interest, I've got I'm doing a Norwegian primary care trial. At intake, their patients are 36. Which is where we used to get them at the end of treatment. It's nowhere where we're getting them now. And in Saudi Arabia, they go in at 38. Now, clearly, in some countries, there's over-treatment, all right, and that's wrong. And I think there's a sweet spot in terms of how severe people should be. But I thought that would just be interesting. Yesterday, I actually showed this slide to Andrew Bennett, who's the clinical director of MSK, and he was like, oh, I need to show that to the minister, can I have it? And it was taken off me. But it's great to see that that's useful and helpful. So what's going on in primary care? Well, there are a couple of really interesting changes happening. One is that primary care, so general practices, are being put into little clusters. They're called primary care networks, and they've been given a lot of sort of autonomy about having maybe more nurses or health coaches or pharmacists, or they get some decision making to meet what's going on in their local community. And this report by Claire Fuller has been really, really big in terms of helping GP practices think about the direction. It's things like streamlining the pathways. It says here, access to care and advice. It's about getting those people sorted to the right place and then making sure that when they get to treatment, it's sort of personalised treatment with someone who really knows what they're doing and can treat the patient in front of them. That's the kind of direction of travel that we need to go. There's also another big change happening, which is there are now 42 integrated care systems, which are called ICSs, and the Hewitt review has come out in April, and it's really giving strategic direction to ICSs. And that's all mainly about trying to focus on bringing health and social care together, but particularly the Hewitt. Hewitt talks about, this is Patricia Hewitt's report, she talks about resetting the finance so that the current sort of power imbalance in financial terms that we have in the acute trust and the community starts to get shifted. And she talks a lot about prevention, she talks a lot about the workforce in primary community care and the importance of starting to build that up again. I have to say both of these strategic policy pieces are really insightful and got lots of wisdom, and I think we need to look at them. In the next area, which is around MSK services, there's been this really important, if I can get my slide to move on, there's been a really important framework that's come out which talks all about this improvement framework to reduce community MSK waits while delivering best outcomes. Now, this is NHS England's team. It's people like Andrew Bennett and Alex Thompson, Chloe Stewart, that team, if you know them. But they say what we really need to be doing is taking an equality analysis, work out, like I showed you the map, where are those communities with all the inequalities, and let's do something about that. We need a much more public health approach in terms of optimising outcomes. And in terms of streamlining, let's start to look at what the guidelines are saying about what patients should be getting and how decisions should be made, and start to monitor that and measure against it and get some benchmark reports. That's the sort of direction of travel that they're wanting. I won't go through all of this, but this is some of the things that they're talking we need to be doing specifically for primary care and specifically for community services. If you haven't read this, I'd really encourage you to go and have a look at it. I'm certainly really interested in the sorts of things that are on here, because I think that's where we need to be looking as researchers. And finally, let me just tell you about the major condition strategy that's come out. It's really good news for MSK. That, there were these 5 major conditions, now we've got 6, and MSK is being recognised, and it's going to bring money, it's going to bring strategy, and it is really going to change things for us, and hopefully a bit more research funding, which would be great. But some of the big ideas that have come out of the MSK strategic team are around employment advisors. Go, Gwen, where are you? And Keele can be really proud of some of the things that we've done that's influenced this. They want services to make better use of digital, because they see that as a way of patients getting faster access to information. They want more what they call MSK community hubs. The idea being there that you put the sort of clinical and the non-clinical together, and the sort of social prescribing. It just doesn't seem realistic anymore to have the physios doing 10 services or whatever they do in the military that gets people so much better. It's in the future, there's just not the funding for that. So that's going to have to come through the local Tai Chi and yoga and walking group, and so there has to be an integration happening there. And lastly, there's a big push now for data, because, as I've shown, there's very little data happening at the moment. And if we're going to find service improvement and leadership happening, that has to be intelligently informed from hard data. So that's the sort of big push. So there's my first section done. Okay, so what have I said? I've said that primary care teams are stretched. We know that. They're on their knees. The current state of MSK health is actually worsening from what I can see. There are some really important MSK inequalities that we need to be aware of. The UK government is doing its piece, and there's lots of policy stuff causing change, and I think we should be aware of those. But the bottom line is MSK primary care is not in a terribly good place. So that's the first bit. Right, let's move to the second bit of my talk. Now, this is a bit lighter. Let's go to some funny photos. So here's me playing the guitar. I'm actually a bit more of a percussion and drums guy, but that was me when I went to Manchester as a student. I was actually born in India. My parents were there for 10 years, and until I was 7, that's where I grew up, and then from 8 I've been in Allestree and Derby ever since, and still live nearby now. The highlight of going to Manchester University, of course, was meeting my lovely wife, Chrissy. On the very first day, we shared a kitchen, and we've been fairly inseparable ever since. But that's us. And then when we graduated, and Chrissy went off to work in Macclesfield as a physio, and I went on to stay at Manchester to do a master's. The master's was great. I ended up actually getting one of my first publications. Let me see if I can get that on here. Here we go. It was all about, for my undergraduate, I'd zapped fibroblasts in little cells and things with this thing called pulse shortwave diathermy. And we found that the cells proliferated and they put down more collagen. And the lab professor, Kay Kilty, her name was, she was a professor of molecular sciences, and she was completely confused why this physio little machine was causing all this effect on her cells. And so she got me to come back and do my master's project on the same thing. In my sort of evenings and weekends, I earned money as a physio working at Wythenshawe Hospital treating the cystic fibrosis patients. And this was one of them drew a picture of me at the time. And she confessed later she meant bone crunching, chest bashing physio, but it wasn't terribly positive about me. But she was a real sweetie, and it was very sweet of her to do that. And one of my supervisors was a chap called Professor Paul Watson, and one of his friends who he introduced me to was someone called Professor Chris Main. So right back from Manchester, I actually know those two very well. So Chrissy and I then moved to Harrowby Drive, actually, in the Westlands, which is just down the hill. It's really close. We both got rotational posts here in what it's sort of the combined UH&M, which is the acute trust here, and MPFT, the community service, and we did all our rotational posts around that. So that's where we lived, and actually when I rotated through to the Hayward Hospital, that's when I first met some of my colleagues like Kay and Krisha. Professor Krisha Jejits, who's now our research faculty dean, was actually doing her PhD just back then, can you believe? And she actually encouraged me to continue my fibroblast stuff with a guy called Derek Matty, who was working in the Hayward at the time. And we were just about to do some sort of research again, and then Chrissy and I decided a rather radical decision. We were going to go off to India as volunteers and work back in India for 6 months. And so that's what we did. And India was very hot and it was very crowded, but we had a marvellous time. Honestly, we had a most fantastic time there, both working as physios. And towards the end of our time, I was asked by the man with the sort of, this is Saranjan Bhattacharjee here. He was the medical director of the physical rehabilitation department. He said, Jonathan, could you stay and do a master's programme? And we really need a master's programme. And I just said, no, I don't have the experience. I was completely overwhelmed with the idea. But he said, OK, we'll go back to England and do a PhD. We need people to have PhDs so they can teach people to do research, at least at master's level. So I blame Saranjan for the fact that I felt inspired to do research. The guys here are Peter and Jenex. They're both now working in the UK and earning lots more money than I am. So I then came to Keele. So when I came back to the UK, there was an advert, and it had Krisha's name on it. And I was like, oh, should I go for that, or should I stay in clinical? And actually, my Chrissy's dad, who's a professor of anthropology, said, oh, definitely go and work in academia. And the story goes that I got my job at Keele because of my ears. Now, Krisha confessed this some years after. So I was interviewed by Peter Croft and Krisha, and apparently the sun was setting in the window behind, and my ears were bright red and glowing, and Krisha was so distracted she forgot to write down any notes about me, and there was no grounds on which they could refuse me the job. So that's how I got my post here. The great thing about coming to Keele was just the sense of family, the sense of all these researchers doing things in the same area. It's really been the most fantastic place to work and to be for all this time. Lots of photos. So the Panther trial, that first one I came to do with Krisha, was around neck pain, and it was comparing pulse shortwave diathermy, and that's one of the little pulse shortwave machines that Lawrence has got on his neck there, and we were comparing that versus manual therapy versus just advice and exercise. And to our surprise, it didn't seem to make a huge difference. The advice and exercise was just as good, and that was a bit of a surprise. So next I went on to the APEX trial. Now Elaine Hay was leading that, but she sort of brought in Nadine Foster as she was training her up as a principal investigator. And it was great fun because we had acupuncture needles that were sham, and we had this clever way of kind of tricking people about them getting this acupuncture for their knee. But to our surprise, the sham was as good as the real, and actually there wasn't a difference. Now, while I was doing that, I was also helping George Peat on his big CASC study as clinical assessment for knee pain. And Peter was encouraging me to do some research, Peter Croft, around neck pain. And he got me to do some, I don't know if you remember this, Peter, but I did some work on some data you had back in Manchester, and that was some of my first publications, actually, around that. And we worked up a fellowship proposal for me to do a PhD, which went to Arthritis Research Council to do a risk stratification for neck pain. But I didn't get it funded. And in early 2003, Peter called me into his office, a bit unsure what to do with me because there wasn't much to do for 6 months. And I was going for an ACORN fellowship, and I said, well, how about I build a house and take non-paid leave? And it all worked out really well. And actually, Elaine and Kate Dunn supported me then to put this ACORN fellowship together. And I moved from neck pain to back pain, and I worked on Start Back. So The Start Back was this risk stratification tool. We were all about identifying predictors, finding a quick way of screening for them, and then matching patients through having targeted treatments, so that it was actually an early step to streamlining the pathway. Yeah, and an important part of it was once you'd identified high-risk patients, you needed the right person with the right skills to treat those complex patients with lots of distress and often comorbid psychological symptoms. And that's where we needed to upskill the physios to do that, and then target those patients to the people who'd had the training. So that was my PhD. It was great fun, and I was really well supported. Thanks, Kate and Elaine, if you're listening online, for your help on that. Next came the main trial. So we managed to get a postdoc fellowship. This time Arthritis Research Council did fund it, and that was so that I could be closely involved with the big team. Elaine was just so industrious back then. She pulled in this person, that person. We had a GP who was, let me get his name, Simon Somerville. Sorry, a bit of a blank there. We had Kika Constantinou. Simon's job was to do the low risk. Kika Constantinou did the medium risk treatment. Gail Sowden really developed the high risk treatment. It was a real team effort. I struggled to find a photo that had everyone on it, so I had to go for two. The one on the left is more like the clinical people who were being trained, and on the right we've got people added like Martin, the statistician, Kate's there, Elaine's there, and Elaine also brought in David Whitehurst as our health economist. He's the chap on the far left of this photo on the right. It was a real team effort, and when it led to a Lancet publication, it was incredibly generous of Elaine to let me be the first author, and it really launched my career, because it's hard, I think, to understate just how big it went. It led to lots of other projects at Keele, but it also led to lots of other work internationally. I found myself talking all around the world at conferences, literally going to lots of different places and getting invited. I think I did 5 replication trials in 5 countries, starting with the Spanish, and then, yeah, it just sort of went elsewhere as well. The other thing I found myself pulled into was lots and lots of translations and validations of that. And that taught me lots about psychometric properties, which is where you sort of look at the measurement abilities of different tools. And I think, what did I learn from all of that? I just reflecting before I move on, risk stratification is not easy. It actually involves system reorganisation. It needs the GPs, the physios, the pain services, the rheumatologists, the orthopods, all to work together. And clearly that's not an easy task. In some contexts we found, particularly overseas, there were very strong financial disincentives or conflicts of interest around people delivering a low-risk treatment. And we've also really found it very hard to do the whole upskilling of people to do integrated physical and psychosocial treatment. And even today, you can either go down one route or you can go down the other route, and it's very hard to get people upskilled. You can't do it overnight, and there's a lot of work that needs to be done to make that happen. And we're not doing terribly well. And the last thing just about this, you have to recognise that our risk stratification tools don't currently have the social determinants in them that lead to those big inequalities, and so they have some blind spots to them, and we need to be aware of that. One of the things that I think came out as well is Gemma Mansell was my first PhD, and Gemma did something called a mediation analysis, trying to work out what worked about the high-risk treatment. And we found it really was the training. It was the ability from the training for those physios that had been trained versus the ones that hadn't to manage the distress and the pain much better. So I'm quite convinced that that is a route to improving care. But the reality has been it's been very hard to replicate in the future, and we've really struggled. Now, 2012 was a real turning point in my career. That's because Nadine particularly, and also Elaine, they encouraged me to start applying for funding myself. And I started initially to do stuff on outcomes. I did something called the MSK Prom. Very pleased with it. All the physios were happy. And then I found out it wasn't really going to get adopted anywhere because I hadn't involved the rheumatologists and the orthopods and the GPs and the psychologists. And so, persuaded by Benjamin Ellis at Versus Arthritis to redo it all, they'd give us some funding if we got... And we went together with Oxford and we did the MSK HQ that you've heard about. And that was a great piece of work. And then, having developed a tool, I wanted to get it into clinical, and the MSK Tracker was the first sort of digital project where we wanted to kind of make the clinicians aware of what patients had filled out at home and then let the patients feel empowered by seeing how they were progressing over time. It didn't go terribly well, if I'm honest. And I also then went on and did the big EU project, the Backup, where again I was responsible for a clinical decision support tool. And I learned some important lesson, I think, from those initial digital projects around the problem when academics are leading the development and innovation. It's really hard to sustain both MSK Tracker and Backup. I think a lot of what we did, if I'm honest, it has been wasted. Because there's no commercial team to when someone rings up and says, could we just have that tweaked so it works with System 1, this particular medical record system, or could you just change it like this? There's no team to do that unless you've got an industry partner involved. And that, to me, has been a real important lesson to learn. So lastly, as I finish this section, a big turning point was when I became professor, and thank you to Pauline and others for that promotion. The opportunities have exponentially mushroomed for me in terms of research, having had that promotion. Currently, I'm still in big data and I'm still in digital. I've counted up, I think, 18 people that I'm responsible for as researchers, and that's a lot of different projects. So if I don't respond quickly to your proposal of PhD chapter, I apologise. But it splits with 14 at Keele. I've got 4 postdocs outside of Keele. And then the projects are the sort of smaller circles. The lighter blue ones are Keele ones. And there are 4 at Keele. And then I've got 4 international trials going on at the moment. The red star is the one where I've got an industry partner with, because I've learnt my lesson. And now I'm working with industry. And in fact, Nathan, one of the CEOs of one of the partners I'm working is here today. Thank you, Nathan. So that hopefully gives you a sense of what I'm doing. There's a lot there. So in summary, section 2's done. My career, 24 years, it could be summarised as a very slow burn. Some people go like this. It's taken me a very long time. I've learnt to partner with industry. I've learnt that even Lancet trials don't change the world. I've learnt not to be too physiocentric. Collaboration is the key. And I've learnt that most clinical trials don't have positive outcomes. Ouch. I think I've done 19 and only 3 have had a positive outcome. It's not easy to get change that's clinically effective. Okay, so now the last bit, on the home straight to going home. So some hard reflection about going forward I've had to make. Do we really want to do more trials, testing one treatment against another? I believe we do, but we need to be very careful before we do them. So how is my research on MSK Big Data and digital going to help? Honestly, is it going to help? What do you think? Let me talk that through just with a few slides as we finish. So the first thing is about, let me tell you about these 2 projects that we're doing, MIDAS and the National MSK Audit and Research Database. They're really very exciting data projects. MIDAS is being led by George Peat, and Roanna and I are doing the National Musculoskeletal Audit. And it's the key thing that we're wanting to do is to see where is earlier I showed you the slide here where I told you what the mean is in all the different settings. It's true that is a mean for one GP practice, but when you look at different GP practices, for example, some of them are up at a 32 at intake and some are as bad as a 20. And it's not just the social determinants that are driving that. So what is the cause of the variation about how easy access it is to get to see your GP and how long the appointments are and whether they've got this service or that service? And actually, we need data. We have a real problem with data invisibility for musculoskeletal patients, and that means that the sort of policy people aren't looking at reports and working out what they're going to do about it. So we need to change. We really need to change our focus on that. And at present, the reality is that all around the country, every MSK service is doing something different. Some are doing self-referral, some are doing social prescribing, some have an employment advisor, some have health coaches. There is a huge variation in what's going on. And we need to start to work out, what does good look like? Where is the best care? And that will only happen from a national audit. So I'm absolutely committed to that. And yesterday, Roanna and I had a really successful meeting down with the Department of Health and Social Care. It was very exciting. They'd got some really, the key people from the MSK Major Condition Strategy team, key people from NHS England, and key people from the National Clinical Audit team, something called HQIP. And we've worked out a pathway to getting our little pilot trial that we're doing, National Audit, onto a pathway to try and get that commissioned so that there could be a national programme around this, which is really exciting. They've put a steering committee together and they're committed to taking that forward, and let's see where that goes. No financial commitments just yet, but definitely a sense of that's the direction we want to go, which is really exciting for us. So that's one big area. We've got to identify the reasons for the variation. We've got to identify best care, interrogate why, and make sure that we emulate that. The next big area for me is about streamlining the pathways. The truth is, you have to have the brain the size of an encyclopedia to remember every MSK pathway if you're a GP or an FCP. There's a different pathway for the finger, to the knee, to the neck, to the shoulder. It's hugely complex, lots of different forms, lots of different criteria for referral here or there, and it's almost impossible for one individual to be on top of it all, particularly when it changes every few months with this directive or that directive. The only way we're actually going to change things is to build pathways and have software systems that allow us to do that. What I call clinical decision support tools. It's the term that you'll see more and more. And two of the trials I'm doing, Support Prim is doing that, and the MSK Pathways trial. Now in MSK Pathways, we're not responsible for the software. I'm not responsible for the innovation. That's coming through. The software is coming through Nathan's team at Crosscover. And then the clinicians in the Birmingham and Solihull patch have put together the sort of orthopaedic specialists and the FCPs and GPs and worked through what they're happy with as their algorithm. You can see just for the back pain one, it's incredibly complex. They've got it down to the point that if you have cord equina and it's out of hours, send them to this, because this is the only place that has got a scanner out of hours, and if it's in hours, send them to this. It's really complex, and it's all in there. And it's very informative. If you get to the end of your sort of diagnostic process, clinical assessment, all the different decisions and things like start back are in there. You can see it tells you the key messaging to give to patients, signposting, what's the management, when should they have a follow-up, and all of that gets saved so that the person who then sees you next knows exactly how you've got there, and you don't have to repeat all of the triage. The poor patients get put through the same thing again and again. And there's lots of work to get this right. We're still a bit episodic, treat everyone as if it's a first time, and there's ways we've got to build in the personalised discharge plans and pick up on. So there's lots to do to get right. But our job is to do an independent evaluation of that, both quantitatively and qualitatively through a cluster trial. We hope to go live in the next few weeks in 40 GP practices. So it's an exciting time. And my big idea, and this is my last slide, you'll be pleased to know, is that we combine our efforts around the national MSK research audit with the data that's coming in from things like Nathan's platform that has every clinical decision made and the treatment and the diagnosis all recorded digitally. Because imagine Lucy and others who love all the prediction models, what you could do with that data. Yeah, it would be absolutely brilliant. We also, with some of the other partnerships, people like Selfback, and we've got all the wearable data now that's being trialled and all the app data, the website data. We could supplement, and in actual fact, last week, I put in an EU Horizon application to do exactly this with a whole bunch of people from around Europe. And it's exciting. What I think we've got to do is switch our focus from the sort of epidemiology perhaps around natural course and predictors to what I would call interventional epidemiology. Which pathway is working best? How do we streamline so we get people to the right place at the right time? And how do we, of all those ideas that the government's come up with about which ones actually work and have evidence and which ones don't? So I'm going to finish there, and I hope that's been interesting, and thank you very much for listening.